dear colleagues. Thanks for this kind invitation. It's really an honor for me to share the stage with Professor Tadej Bartolino. So thanks, Tadej, for this introduction. The first slide, I would present our experience in type 2 diabetes patient in Italy under basal insulin treatment. Type 2 diabetes mellitus population in Italy is primarily composed of old patients with an average age of 70 years old, with some comorbidities such as chronic kidney disease, 30%, and 14% of cardiovascular disease. This can be represented as fragile population. And according to the Annals, one of the most comprehensive database in Italy on diabetes mellitus, over 20% of type 2 patients are under basal insulin plus oral drugs. And in this cohort of patients, the glucose control is not optimized. Looking at the HbA1c level in this population, they have a worse glycemic control, similar to patients under MDI treatment. So, what are the challenges associated with this kind of therapy? Fasting glycemic control can be achieved by a proper basal insulin titration, avoiding hypoglycemia. And postprandial glycemic control can be achieved by selecting the proper oral drugs or by educating the patient to auto-management of the diet. And for both these targets, the availability of the full history or glycemic profiling of this patient is crucial, is very important to optimize their glucose control. So let's discuss my first clinical case. This is a male, 50 years old, low weight, suffering from hypertension, and he has not tolerated CGLT2 inhibitor and GLP-1 analogs. His therapy is glargine 20 units per day, plus sitagliptin and metformin twice per day. He has poor diet compliance and severe hyperglycemia with a value of HbA1c of 87 millimolar. So the question is, what therapeutical option would you prefer for this patient? Of course, it's very important to stress diet compliance, but please select one of these options, add rapid insulin, stop sitagliptin, metformin, add glitazone, increase basal insulin, or add sulfonylurea. Few seconds to select one of these options. Okay. Very well. Increase basal insulin and add rapid insulin, stop sitagliptin, metformin. Okay, we can stop. We can stop the, okay. And if the glycemic profile are available, would you reconsider your decision? Look at the glycemic profile. You can observe a severe fasting hyperglycemia. Sorry, just a moment. Okay. In this patient, we decided to simply increase the basal insulin level up to 40 units. And we stress, of course, the diet modification. The patient was resistant to start an MDI treatment, and they show a really poor compliance to the diet and to physical activity. So we decided to simply increase the basal level, and if you observed the glycemic profile 3 months later after this modification of the insulin basal therapy, you can observe a significant improvement of his glycemic profile, although it is not optimized yet. Thus suggesting that the observation of the glycemic profile thanks to FGM system aided the physician to define the best therapeutical option for this patient. Move on to the second clinical case. This is a male, 64 years old, obese people with type 2 diabetes mellitus and hypertension, suffering for moderate chronic kidney disease. His therapy consists on CGLT2 inhibitor and GLP-1 analogs plus glargine 60 unit. His glucose control is not optimized with a 60 millimolar of HbA1c level. And the same question, what therapeutical option would you consider for this patient? Select one of these options: diet modification, increase basal insulin, add glitazone, or add acarphage. We can wait. Oh, most of you. Increase basal insulin. Okay. If the glycemic profile are available, would you reconsider your decision? You can observe a significant glycemic variability and some postprandial glycemic peaks. So in this case, the successful strategies was simply the modification of the diet. The observation del glycemic profile confirms some postprandial glycemic peak, but the patient autonomously decided to modify the diet by selecting the proper type of food, reducing the amount of food in order to prevent the hyperglycemia peak postprandial. And diet modification of the patient has led to reduce time above range and increase time in range in this patient, thus suggesting that the possibility to have the glycemic profile aided the patient to the auto-management of the diet, empower the patient to the management of his diabetes. So the conclusion to these cases is that in people with type 2 diabetes, Freestyle Libre system facilitates basal insulin titration and the self-management of postprandial hyperglycemia in people not on MDI therapy. And this paper has summarized our experience in Italy on this type of patient, that are under basal insulin therapy plus oral anti-diabetic drugs. The study was conducted in 2 hospitals, our hospital, Ospedale Niguarda and Ospedale Civili di Brescia, and was an observational retrospective real-world study on 132 patients. The median duration of diabetes was 19 years. The baseline HbA1c level was about 8%. Primary endpoint was the changes in HbA1c level at 3 and 6 months after the use of Freestyle Libre. These are the results. You can observe that the use of Freestyle Libre 2 system in people on basal insulin significantly improve the HbA1c level with a reduction of about 0.4% at 3 and 6 month follow-up. Even analyzing the data in a separate way of patient only in oral drugs or in basal insulin plus oral hypoglycemicant, there was a significant reduction at 3 and 6 months in patient basal insulin plus oral hypo, and at 3 months in patient only with only oral hypo. By the analysis of CGM metrics, we can observe a significant decrease even of time below range from the data available at 6 months compared to the data available at 3 months. Baseline data were not available because the patient baseline in this study did not wear the CGM system. So, thanks to this experience in Lombardia, one of the Italian region with the largest diabetic population, about 500,000 people with diabetes are in this region. The reimbursement of FGM was recognized by the national healthcare system. And for patients with type 2 diabetes mellitus under multiple daily insulin injection, but even for patients on basal insulin therapy only. In this case, however, the prescription should be limited to 1 year. And after the first year, the physician has to verify the correct use of the device. But this system can be prescribed also for people on hypoglycemic therapy only for 3 months period in the case of some specific conditions such as the risk of hypoglycemic episode, therapy modification, glycemic decompensation. Thank you to you.